Okay, hey everybody. This is Jim Pitts. I'm one of your instructors for the pharmacotherapy class this semester. Today I'm going to be doing week 2's lecture. We're going to talk about rational drug selection, adverse drug reactions, and over-the-counter medications. So we're going to hit a couple topics in this lecture. I'm going to try to keep these, short and to the point, because I know you have a lot of other stuff going on. So my plan is to kind of add to the slides that are up. So I'm not going to cover everything that's on the slide, and I may not cover each slide individually, but I'm going to try to add little notes and little bits of knowledge to what's in your slides. You'll see coming up that these slides are based out of your book, but I've taken some of them, rearranged them, and added my own slides to it. So my own slides are going to be blue in background with black font, and that's stuff that's added from my own notes or own experience and other references. So that's why there's two different looking slides. The ones that are on the screen right now are from your book, and the blue ones are mine. So let's go ahead and talk about rational drug selection. So rational drug selection really is just the patient receiving appropriate medications at the appropriate doses and for periods of time. So this could be selecting the right, just a good example is selecting the right antibiotic for a certain type of infection. Once the infection has been cultured, you know what it's sensitive to. You would want to pick an antibiotic that it is susceptible to. Maybe it's recommended for a 7 to 10 day cycle, so you don't want to cut it short and increase the risk of recolonization or give it too long because it's just unnecessary side effects to the patient. And also you would want one that's probably the least or the most cost effective to the patient. Just because something is brand name and new doesn't mean it's more effective than what's been on the market for a long time. And it's actually contrary. Most of our old school, kind of thought of as old school medications, tend to be more effective than the new drugs coming out because we've had a lot more time to study them and see. And we'll talk about throughout the semester kind of the effectiveness of certain medications versus the new medications coming out and really, how well they work and their cost associated with it. Because if a patient can't afford their medication, they're definitely not going to take it. So the WHO model for the process of rational drug prescribing is pretty easy. You want to define the patient's problem, specify the objective. So like with that infection we talked about earlier, is clearing the infection. You want to collaborate with the patient because you have to make sure the patient knows what they're taking, why they're taking it, and what they can expect, what outcomes they can expect, side effects, and like the infection, the clearing of the infection, alleviating any pain or inflammation they may have, etc. Choose the treatment, educate the patient, and then monitor for effectiveness. And that may be short-term or long-term depending on what problem we're treating. So in defining the patient's problem, you want to assess the patient, develop a working and differential diagnosis. This includes looking at other diagnoses that could be causing these problems and other medication that might be causing these problems. What you don't want to do is to add on a medication that is treating the side effect of a medication they're already on, unless you absolutely have to. Sometimes we do. Sometimes medications that are absolutely necessary, like chemo, they're going to cause nausea and vomiting. You're going to add on something for that nausea and vomiting. But if it's a side effect that of a medication that can be changed, you want to look into changing that medication first. So you're going to develop a working and differential diagnosis based on the medications that they're on and how they present, using diagnostic tests to confirm, and see if there's a clear indication for drug therapy. So you definitely want to specify the therapeutic objective, the goal to treatment, and you want to make sure the patient knows what this is. so that they have a realistic expectation of what they can expect from the medication. You don't want them to get frustrated and stop their therapy early or refuse to take it. So in choosing the treatment, that first bullet on the slide is very important. Using evidence-based guidelines. They change fairly often, every 2 to 3 years on average. Hypertension and dyslipidemia have changed, it seems like, every 6 months, depending on what organization you're using. They may not always be the same, depending on, with hypertension, if you're using the American Heart Association or the American Society of Hypertension, but they're going to in general be the same or be similar, and you want to use something that has some evidence base, because most of those are based on based on trials for that disease state. You want to individualize for each patient, use a step-by-step decision-making model, and as you gain experience, you'll be able to kind of identify patterns that your patients present with. As you can see, I just skipped a slide. I'm not going to talk about each slide because there's no reason for me just to read the bullets. Each slide's still important. Doesn't mean it's not, or it's not going to be covered on the test, but there's no reason for just me to read what you can already read. So when you start treatment, patient usually fills a prescription at the pharmacy. That's self-explanatory. When you're writing a prescription, you want to discuss whether the patient has the ability to pay for the prescription. A lot of things play a role into this. One, insurance copays. Obviously, generic drugs have a lower copay than brand name drugs, and each patient, especially if they have insurance, they're going to have a separate formulary that their insurance will pay for. So, when you're looking at medications, they may pay, out of all the ACE inhibitors that we're going to talk about for high blood pressure, there's about 10 of them, their insurance company may want to pay $4 for a certain one, $10 for another one, and then $50 for a third one. So they all work the same. So you may want your patient to, if they have the ability, to bring in their formulary with their insurance that their insurance has, or to have it on their phone. A lot of them have apps now that you can download, or PDFs you can download to your phone. It's going to save you a lot of time where, if you didn't have that, you're going to prescribe something, your patient's going to call back saying they don't cover it. You may have to try again. You may have to do a prior authorization for the insurance to cover it. It'll save you a lot of time, to where if you can see that, you'll know what your patient's insurance will pay for, and then ultimately what your patient can get filled at the pharmacy. There's a mention on here for $4 retail lists. Those do change all the time. It's based on, obviously the cost of the medication to the pharmacy, but they're a great resource. So if you can have somebody, if you got a pharmacist that that you work with a lot, if you can have them send over, quarterly their $4 list or free medications at Publix, it's a great thing for your patients to have the opportunity to use. So, if you want more information about that kind of stuff or anything we talk about in these lectures, just shoot me an email. I can put you in touch with people that have information on this if I don't have it myself. So educating the patient. This is very important. Poor adherence contributes to worsening disease, hospital admissions, and death. I know that 1 in 5 new prescriptions are never filled, and 50% of the other 4 are taken incorrectly. That may be missing doses, wrong time of day. They take them at too many at once. What you want to do is, if you want to judge adherence, ask your patient, how often do you forget to take your medication, or how often do you remember to take it, as opposed to, are you taking it? When you ask a patient, are you taking it, one, they'll get defensive and say, of course I'm taking it. Absolutely. How are you taking it, or how often would you say you forget it? Gives them a little bit of leeway, and they'll be more honest and say, 2 days out of the week, I probably forget it. Or, I only remember it. I always remember my morning dose, but I forget my bedtime dose. You'll get a lot more information if you if you ask that open-ended question, instead of just saying yes or no, are you taking it? So drug factors that influence drug selection, pharmacokinetic factors, which are the absorption, excuse me, disposition, the distribution, metabolism, and excretion of the drug. We're going to talk about later, and we're going to talk about more about that in your intensive when you come to campus and for all those lectures. So we'll focus on that later. The pharmacodynamic factors is how the drug works at receptors and in the body, what actual effect it has. Therapeutic factors, what the results are going to be, safety, cost. I can't stress how important the cost of a medication is to a patient. Luckily, we've just had new legislation go through, a lot of new legislation that is changing how insurance plans can operate. So it should help with access to drugs and how they can be charged. So hopefully that'll increase availability of medication to patients. So in general, a formulary is a list of possible medications. If you work at a hospital, your hospital will have a formulary of possible medications you can order for your inpatient patients. It's what the pharmacy has. It's what they're able to monitor. In outpatient, your formulary is your list of drugs that a patient can get filled at a pharmacy. The formularies have to include a drug from each category, but it will then tell you, okay, is it a tier 1, tier 2, or tier 3 medication, with tier 1 being least expensive, tier 2 is the middle, and tier 3 is the highest expensive, or most expensive. So you want to try to be familiar, and as you practice, you'll learn that the older generic drugs tend to be, tier 1 on formularies, and they're very effective, and we'll talk about their efficacy later. But always keep that in mind, that the patient's formulary for their insurance does play a big role in what they can actually get filled. Okay, adverse drug reactions. Adverse drug reactions happen all the time. Basically, the difference in a side effect and an adverse drug reaction is how severe it is and how likely it is to happen. So an adverse drug reaction is any undesirable or unintended effect following administration of a medical product, whether or not the effect is considered related to the medical product. There are over 2 million serious adverse drug reactions annually, and the highest risk are children, elderly patients, and patients with renal impairment. And that renal impairment inhibits clearance of the drug, so you end up getting higher levels than you would expect of the medication, and it can become toxic. Ways to predict ADRs: age, young and old, very easy. Children are not small adults. They can't be treated the same way. They have different kidney function, liver function, distribution of drugs throughout their body. And the elderly, as you get older, you lose muscle mass. Your kidneys don't work as well. Your liver doesn't work as well. It's easier to have mental status changes. You can be more sedated, things like that. So that's your first predictor of an adverse drug reaction. Body mass, you want to look at patients that are either very, very skinny or obese. And based on gender, women tend to have more of certain adverse drug reactions based on pregnancy changes or just body fat composition. You can also predict based on environment, time of administration, pathological state, genetic factors, and psychological factors. Types of ADRs are important. The most you're going to see are type A and type B. So type A is a predictable factor. Just for example, Depakote, a seizure medication also used for bipolar disorder, is known to cause thrombocytopenia, or a drastic platelet reduction in some patients. We know it happens. It could be considered a side effect of this medication, but that would be a type A reaction. It's a pharmacological reaction we know happens, and it's dose dependent and it's predictable. Type B is idiosyncratic. It's not dose dependent. You can't predict when it's going to happen. It doesn't occur because a patient's on a lot of that dose. It's just it happens when a patient is on it at some point. And that can happen with it could be harmful or less serious side effects, and I'll point some of those out as we're going through lectures later on. All right, factors that foster positive outcomes. A few notes on this chapter. 50% of patients adhere to a drug regimen at 6 months. And adherence there, it depends on the definition, whether they're still taking it, whether they're just getting it filled at their pharmacy, or whether they're taking it exactly as prescribed. Even less than that 50% take it exactly as prescribed. And we're not talking about that person who forgets one night a month. A large percentage of people, for various reasons, don't take their medication as prescribed routinely. They forget all the time. Only 30 to 40% are still adherent at 1 year. A lot of factors that play into this. Great one is under that high risk bullet: asymptomatic diseases such as hypertension, dyslipidemia. Those are patients who have clotting disorders and need to be on an anticoagulant. You don't feel those when you're hypertensive or your cholesterol is high, and you may even feel worse starting off when you start a medication. So patients are less likely to continue it. Now, usually after a week or two, the side effects resolve and you can't tell, but they're less likely to take it if they don't feel an effect. Patients with cognitive impairment, especially older patients, patients with Alzheimer's or some kind of dementia, are at risk for noncompliance. Psychiatric illness: if you don't think you're sick, you're not going to take your medication. And complex regimens. Any medication that has to be given 3 to 4 times a day is a lot harder to remember than one that just has to be taken in the morning. So you want to try to pick a medication that's effective, but is also easy for your patient to take. Nutrition and nutraceuticals, always a big area that we get asked about by patients. Not very well regulated, so there's easy access. Sometimes makes false claims about their efficacy. You can see in the additional documents I've posted on this on over-the-counter medications and complementary medications. There should be some notes in there about which ones are actually effective or which ones we don't know about. There are a few notes I want to touch on with this chapter. Influence of diet on drug absorption. This can be really big. So drugs can be the absorption can be decreased, delayed, accelerated, or increased by food. It can be because of GI tract motility. So if something slows down the GI tract, more of it can be absorbed. Changes in pH. There are several drugs that require an acidic environment to be absorbed. So if your patient's on medication for heartburn, it's not going to be as effective. There's some that bind with medication. The example here is tetracycline in milk, or they may, a lot of there's some other antibiotics that bind with calcium, aluminum, and magnesium. So so if you're taking it with a supplement or even just a daily vitamin, it's not going to get absorbed. Some drugs are better absorbed with food. Griseofulvin's a great example. One in my area of psychiatry, or two, Geodon and Latuda, two antipsychotics, have a set amount of calories they have to be given with. Latuda has to be given with 350 calories and Geodon with 550. So if you have a patient who's taking it at bedtime, even if they take a bedtime snack, they're still not going to get to that required number of calories that's needed for absorption. So those are ones to keep in mind, or to maybe create yourself a little cheat that, you got to tell the patient to take them with breakfast and dinner, not just with a snack. And even fasting for extended period of time causes vasoconstriction, leading to decreased drug absorption. Influence on diet and drug metabolism. Some of this is pretty important. Grapefruit juice and cytochrome P450 3A4. We're going to talk a lot more about drug metabolism in your intensive. So you just read through this in your book, be familiar with it for when we talk about it. But grapefruit juice inhibits cytochrome P450 3A4, which is a common enzyme for your statins, for cholesterol medication to be metabolized through, calcium channel blockers, and some immunosuppressants for patients who have had organ transplant. So it's very important that they keep a steady level of these. And if you give something that inhibits its metabolism, they can become toxic. So drug and food incompatibilities. These happen more than you would think. The best example is warfarin and vitamin K containing foods. Right here it says spinach. It's really any leafy dark green vegetable. There's actually a lot of stuff that contains vitamin K, mayonnaise, blueberries, several other things. And Coumadin, the brand name of it, actually has a book that you can get for free and give to patients, and it'll tell them what foods are high in vitamin K. And the important thing is they have to keep those foods consistent in their diet. They don't have to avoid them, but if they keep them consistent, then you can adjust the dose to make up for, if they're eating a lot of vitamin K containing foods or a little. Monoamine oxidase inhibitors are old medications and antidepressants that are also used for Parkinson's. You can't have tyramine containing foods. So those are fermented foods, certain types of aged cheese, pickled foods, things like that. You have to be very careful to avoid it because it can actually send a patient into a hypertensive crisis. Metronidazole, Flagyl, commonly used for bacterial vaginosis or other infections, because Clostridium difficile, interacts with alcohol, and it has the same interaction that Antabuse does, and that's a drug we give to alcoholics that when they drink alcohol, they get severely ill and vomit. And it's kind of a negative feedback for drinking alcohol. Well, if you've got a patient who's on metronidazole, you can actually get that same reaction, not just from drinking alcohol, but from mouthwash or from over-the-counter cough medications that contain alcohol, or even hand sanitizer. You can get enough of an absorption from, say, like Purell, that you can cause that upset stomach, nausea, and vomiting that the Antabuse causes. So you really have to keep that in mind and try to educate the patient as much as you can. The big thing I like to talk about with nutraceuticals, just the important part is look at the evidence for them. There are some that are very effective and have been shown to be effective, and there's others that are just a complete waste of money. Fiber is great for patients who are constipated or have problems with motility. Best to get it through dietary fiber, but if you need Metamucil, it's very effective. Vitamins and minerals, for the most part, it's hit or miss. with those, whether actual high doses of vitamins work. Everybody loves vitamin C for a cold, but there's actually no trials that show that it's effective for prevention of a cold, based on it itself. Usually it's the patients who drink things high in vitamin C, not who take vitamin C tablets. Plant sterols, pre and pro symbiotics, just look at the evidence behind them. You may have a patient who's adamant on taking it. You may have to think, it's not going to harm them. Let's let them take it. But watch out for things that are ineffective or things that may cause drug interactions, because even those can interact with other medications. Vitamins, very important to get a well-rounded vitamin regimen. I like to tell everybody, before you start prescribing people over-the-counter vitamins, nothing's more effective than getting all of your daily vitamins from your diet. That's where all these vitamins that hit the market and all these special formulations, that's where they get their evidence, is that we know vitamin A is vital for vision and bone growth and reproduction, so it makes sense that supplementing vitamin A would make that better. We have very few trials that actually show, for instance, people with poor vision, if we give them vitamin A tablets, that their vision gets better. So it really shouldn't be seen as a cure, or it should really only be given for patients who lack that vitamin. And if you want more information about vitamins, their efficacy, you can refer to the complementary medicine document that I have posted. I have a lot more stuff on it. Don't get me wrong, I do think there are benefits to adequate levels of vitamins, and certain vitamins have good evidence, but not everything does. And for the most part, a daily multivitamin is all that your patient needs. Something good, all-inclusive, like a Centrum or something like that is really all your patient will need. Folate, I always like to point this one out. Critical for patients who are pregnant, or thinking about getting pregnant. If you have a patient who's thinking, or they're trying, go ahead and recommend them to start folate. That way they're on it in case they do become pregnant. They haven't missed a month or two of taking that. If you have questions about certain things, shoot me an email. Fatty acids, fish oil, things like that come and go, whether the evidence is positive or negative. But a lot of these things overall, it doesn't hurt for the patient to take it. Might be beneficial. So usually you can go ahead and recommend, if your patient is adamant about taking it, to let them go ahead and continue. Herbal and complementary therapies. So, herbal and complementary therapies is a very sticky subject. This is, all of our complementary therapies, when you're looking at things like ginseng and evening primrose and these things over the counter that talk a lot about being cures for certain diseases, they're not. They don't have to provide evidence of treating these illnesses. And contrary to FDA-approved drugs, which have to have trials that they are safe in humans, they're effective, and they don't have any negative side effects, complementary medicines and in general over-the-counter supplements can come on the market, and the FDA has to prove that they are harmful or they are not what they say. So there's a definite drop in the quality of these products in general when you're comparing them to FDA approved products. You always want to look with complementary medicines at drug interactions. A lot of them, especially St. John's wort, has a lot of drug interactions. So always look at that and make sure you ask your patients, when you ask them what drugs they're on, make sure you ask them, are you on any other over-the-counter medications or complementary alternative medications? Because they may not consider them when you're asking. And most patients will think, oh yeah, I'm taking melatonin for sleep, or I'm taking something else. So make sure you ask for that and get a complete record for your patient, so you can just make sure there's no harmful drug interactions. There's a more complete list of complementary medicines posted in your additional documents section of this chapter. If for some reason it won't open or you can't get to it, let me know. But it's got a pretty good breakdown of the top choices over the counter of certain medications, and which ones are effective, common side effects, and which ones have a lot of drug interactions. Information technology and pharmacology. So, the primary benefit of this is to decrease prescribing and transcription errors when computerized provider order entry is used. Nothing's perfect. A lot of times, even the computer can mess up and pick the wrong thing, but it definitely provides a benefit of not having to use handwritten notes, which cause a lot of medication errors. It helps standardize patient education and helps us to constantly do quality improvement, because we're able to pull information out of the documentation that can be analyzed. Pharmacoeconomics. This is a very interesting topic if you like the business side of medicine. It's the analysis of the cost and consequences of any healthcare-related treatment service. Basically, it's where are you getting the value for the money for the medication. Your book goes more in depth into pharmacoeconomics, and if it's something you're interested in, let me know. I can put you in touch with some people who deal more with this, comparing one treatment to the other and where the true benefit lies. Over-the-counter medications. So a lot of over-the-counter medications are taken. This includes pain medications, muscle rubs, not necessarily vitamins, but things that are clinically proven, but the FDA has said that they can be over-the-counter. A lot of your proton pump inhibitors and things for heartburn have just recently, in the past couple years, hit the over-the-counter market and no longer require a prescription. But they're very common. Very, very common. So always ask your patient if they're taking one when they come visit you. Obviously, you can see here that annual OTC medication sales, the top is cough and cold medications at $4 billion. OTC analgesics are a big one. Of course, that's naproxen, Motrin, Tylenol. Things that commonly used for headaches or small pains. Heartburn has jumped up a lot with the PPIs and H2 antagonists becoming over the counter. Laxatives, acne, diarrhea, and nicotine replacement, which continues to grow as people try more and more to stop smoking. What's amazing is that there's all this money spent on over-the-counter medications, but for a lot of these categories, there's only 5 to 10 options in each one. Take cough and cold medications. You can go down an entire aisle of cough and cold medications with all these different brand names and combinations, but truth be told, there's only about 10 medications for that area. But they're given in different combinations, and that's where all those options come from. The only cough suppressant there is over the counter is dextromethorphan. So it's the active ingredient in NyQuil and Tussinex and some Robitussin. It's all the same. It's all dextromethorphan. So everything that's for cough has that in it. nasal decongestants. There's, over the counter without, there's phenylephrine and there's pseudoephedrine. That's it. But it's overwhelming when a patient goes in and tries to look and figure out what's the difference of these options. And as they come out with more and more combinations, they really need help looking through it. So it's important to recommend to your patients that when you go in, if you want to know what the differences are in them, ask the pharmacist. They're more than happy to come out and go over what each ingredient means and what the differences are in these medications. So over-the-counter drug has the following characteristics. It must be safe. It has to have a low potential for abuse. It has to be labeled. The patient must be able to self-diagnose the condition, which is why a lot of medications might be safe, but they're still required to be prescription only because the patient can't self-diagnose what's going on. But the patient has a headache, it's a normal headache, they can go get the ibuprofen 200 milligrams that's over the counter. There are still hazards of over-the-counter self-medication. No drug is perfectly benign. You'll hear the term black box warning, and those are warnings that are given to medications by the FDA to emphasize their risk. Ibuprofen, Advil, has, I think, 8 of them. And think about how many times people just go buy ibuprofen over the counter and take it. It doesn't mean that ibuprofen's dangerous, but it can have toxic levels and overdose. It can be harmful to your to your organs. People can take it and overdose and die from it. You can have acetaminophen toxicity. Decongestant medications shouldn't be given to infants and children, and also they shouldn't be given to patients with uncontrolled high blood pressure. Decongestants act as stimulants, and they can raise your blood pressure to a hypertensive crisis. So just because they're over the counter doesn't mean they're 100% safe, but they usually given in the right amounts, they can be effective and safe for your patients. Over-the-counter medications do have adverse effects, so you want to make sure your patients know that. Just because it's over-the-counter doesn't mean it's completely benign. And again, that's why the pharmacist is there. They'd love to answer questions from patients if they have questions on over-the-counter medications. You can't abuse over-the-counter medications. Dextromethorphan can be used to get high if it's given in high enough amounts, and pseudoephedrine is used to make meth. So the law actually restricts its daily and monthly the amount that you can buy, and is kept behind the counter, and the patient has to show a driver's license in order to be able to buy it, and so the government tracks how much they buy. Patient education, you want to make sure they always read the label, follow the label instructions, ask a pharmacist or provider about drug interactions, and you want to educate them that over-the-counter medications are real medications and can have the same adverse effects as prescription medications. So this is the last slide in this lecture. If I'm going too fast or skipping parts, let me know. If you have questions about what I've said or would like more information, again, shoot me an email, post it in the discussion thread of Canvas. It comes straight to my phone, so I can respond fairly quickly. Or I can put you in touch with someone who if you're just looking for more information, I can put you in touch with somebody who focuses in that area of pharmacology. I hope this works well. I'm looking forward to this semester, and if anything else comes up, just let me know.